So let's talk about ARDS, Acute Respiratory Distress Syndrome. So it's not good enough just to be able to say what it stands for, right? We got to know what it is, what it's caused by, the patho underlying, and the most common or most pertinent clinical manifestations and the most common clinical manifestations, and then a few interventions. So first of all, you don't just wake up with ARDS. This is a very, very severe respiratory disorder, okay? It is the end result of many other potential underlying conditions. And those are sepsis being number one, pneumonia or just respiratory infection in general, some sort of trauma, shock state, aspiration, but we're going to go with sepsis because sepsis is the most common. So what does sepsis set into motion that leads to the development of ARDS? Well, sepsis leads to widespread severe inflammation. And that widespread severe inflammation that is targeted in the lungs damages the alveolar capillary membrane, which is where gas exchange takes place. So oxygen is supposed to leave the alveoli and enter the blood, while CO2 is supposed to leave the blood and enter the alveoli to be exhaled. All right, so keep that in mind. So we've got damage to that alveolar capillary membrane. That causes that capillary to become very permeable and to leak. At the same time, the type 2 alveolar cells are damaged as well. Those cells produce surfactant. So now, we have two main underlying pathophysiological processes responsible for the large majority of the manifestations that we see with ARDS. So we have damaged alveolar capillaries that are leaking, and that causes pulmonary edema. We have damage to the type 2 alveolar cells, which decreases surfactant production. That decreases lung compliance. So now we have pulmonary edema. So we have fluid that has leaked, now kind of separating the alveoli from the capillary. And we also have alveoli that are less compliant or less receptive to being inflated because of the decreased compliance. All right. So picture this. We have an alveoli and a capillary that when they come into contact with each other, gas exchange takes place. But now we have fluid separating the alveoli from the capillary, and we also have an alveolus that is not compliant to being inflated because of decreased compliance, because of decreased surfactant production. So those two things are now impeding gas exchange because the alveoli cannot come into contact with that capillary bed for gas to be exchanged, for CO2 and oxygen to be exchanged. So those are the two big underlying pathophysiological processes. Remember that. So pulmonary edema, decreased lung compliance. So what are we going to see? We're going to see all those things that we see with infection, with inflammation, right? Increased WBCs, fever, an increased CRP, which just signals inflammation. We'll hear adventitious breath sounds like crackles, rhonchi, wheezes, obviously a cough. As the hypoxemia worsens, we'll see the patient become restless, agitated, and we know that mental status changes are one of the earliest indicators of severe hypoxemia. Always remember that. Don't ignore your mental status changes. And then obviously dyspnea, tachypnea. None of that stuff is really going to distinguish ARDS from other respiratory disorders, right? But what does? Number one, something called refractory hypoxemia, meaning that however much oxygen we give these patients, we can give it till the cows come home. It's not going to improve their oxygen saturation because what's happening to cause that hypoxemia is a separation of the alveoli from the capillary, okay? There's a separation there. So we can stick a binasal on them, turn that FiO2 up. It's not going to improve their oxygenation. So refractory hypoxemia, meaning hypoxemia that is refractory to oxygen. We're going to see respiratory acidosis. We're going to see a white lung on x-ray because of so much fluid, because of all the pulmonary edema. So whited out lung on the chest x-ray. We're going to see a very low PaO2 to FiO2 ratio. So that kind of goes back to what I just mentioned about refractory hypoxemia. PaO2 is partial pressure of oxygen, and that's normally 80 to 100. FiO2 is fraction of inspired oxygen. So room air is 21% FiO2. All right. So that ratio, that PF ratio, or PaO2 to FiO2 ratio, is going to be less than 200. Okay, that's a hallmark sign of ARDS. So that means that the PaO2 is not going to go up as the FiO2 goes up. Okay, so in other words, they could be getting 100% oxygen or 100% FiO2, and we're not going to see much improvement in the PaO2. All right, so what do we do for these patients? Well, obviously, all the things. We're going to check the ABCs. We're going to assess respiratory status, respiratory effort, all the things that we do. But we're going to do a couple of unique things. So prone positioning kind of became one of those standard treatments when, COVID became so rampant and everybody was going into ARDS. So what prone positioning does is it helps perfuse certain areas of the lung bases that don't otherwise get perfused in the upright supine position. So we found that early proning before ARDS even set in with COVID patients would kind of prevent ARDS from happening sometimes, and we saw much better outcomes in patients that were placed in the prone position early on in their COVID diagnosis. I think some recommendations were like, for a few hours a day, depending upon the patient's condition and things like that. Now, once the patient becomes sick enough that we have to place them on the vent, which is very common with ARDS, what we're going to do is we're going to give them high levels of PEEP. That is positive end expiratory pressure. So what that is that's an extra puff of pressure at the end of exhalation to really open up that alveoli. And so think about that pathophysiologically. The reason for that is to open up that alveoli because it's not coming into contact with the capillary. So we've got to open it up, we've got to puff it up so it will come into contact with the capillary in order to allow gas exchange to happen. So prone positioning and higher levels of PEEP when placed on the mechanical ventilator are kind of two mainstays of therapy with patients with ARDS. Obviously, we're always going to treat the underlying cause with antibiotics and whatever else is the main underlying etiology. But remember those two nursing interventions that are very important in patients with ARDS. I hope this has helped. This is just a little picture that I found on Pinterest. I have another picture that I created myself, an infographic that just kind of sums up everything that I just talked about that I'm going to put at the end of this video. But again, I hope this helps. Happy studying, happy semester, and go Vols!